Greeting everyone. I am Dr. Deependra from Conceptual Orthopedic and I welcome you all in today's connect session with Professor Anil Dhal sir. And today, sir will be discussing the follow-up case which sir has already discussed. One case of a tibialization of the fibula and another one is a gap non-union reconstruction in a 2 years old boy. So I think this talk is going to be very useful to all of you. So without any more delay, I welcome you, sir, on the board and I request you to start the presentation. Now it's over to you, Professor Dhal, sir.
Thank you, Deepinder. So, good evening, all the participants. Today, I'm going to show you the follow-up of two cases which have already been discussed on this e-learning platform. One of them, the first one, is an Ewing sarcoma of the child's leg, in which we had done a resection of the tumor followed by tibialization of fibula. So this case, just to recapitulate, initially there was a 6-year-old girl who presented to us with pain in the right leg of 2 weeks duration. And along with that, there was a swelling in the right leg of 1 week duration. There was no fever, no loss of appetite or weight. And this was the X-ray of this patient, which was showing a laminated type of periosteal reaction along with a lytic area, which was also destroying the cortex and the medulla, corticomedullary destruction. And what we found on the core biopsy, it was reported as consistent with Ewing sarcoma because the immunohistochemical staining was positive for CD99. So, as is usual for these patients, a multi-modality approach has to be incorporated. So, initially, new adjuvant chemotherapy was given, and thereafter, surgical excision and reconstruction program was instituted, which was followed by adjuvant chemotherapy. So you can look at the pre-chemotherapy X-ray and thereafter the post-chemotherapy X-ray just before we embarked upon the excision. And also, if you look at the MRI, which was pre-chemotherapy, there was a lot of soft tissue component coming in the pre-chemotherapy stage. But on the right, if you can look at it, now it seems that the tumor is confined predominantly to the bone, and all that extra cortical extension has disappeared. So at this stage, we embarked upon the excision of the tibia, and you can see that the periosteum as well as the biopsy scar has been included with the excised specimen. And this left us with a gap, a huge gap was left there, and this needed to be reconstructed. So we incorporated a very, very time-tested procedure, which is very useful in the children especially, which is known as tibialization of the fibula. The procedure was performed in 2 stages. In stage 1, we sectioned the fibula somewhere around the neck of the fibula after exposing the common peroneal nerve and protecting it. And then we implanted the fibula and to the side of the lateral aspect of the tibia, proximal tibia. And in the second stage, which is known as Huntington's stage 2, we did a similar procedure by doing an osteotomy of the fibula somewhere here, and then decorticating the lateral aspect of the tibia, and then implanted the fibula in juxtaposition to the tibia. And this was the post-operative X-ray. You can see that the fibula has been sort of more or less pushed into the medullary canal of the proximal fragment, but it is on the side of the distal fragment. So this was the immediate post-operative X-ray of this patient. And thereafter, we followed this patient up, and this is the X-ray taken at about 6 months' time on 1st of July 2024. And you can see that the fibula is more or less united, both proximally as well as distally. And you can see how beautifully the fibula has also united to its parent proximal fragment and the distal fragment. The alignment is very good, both in the AP as well as the lateral view. And at this stage, we initiated this patient on weight bearing within the cast. So this patient was given a long leg cast because if you look at it, the proximal end is small. So we could not have relied only on a PTB cast. We could not have relied on a PTB cast. So thereafter, we gave him an above knee POP cast, and weight bearing ambulation was started. And this is going to be the future plan also in this particular patient to follow him up in the OPD on a monthly basis. So this is on 1st of July, and this is the latest follow-up of this patient on 29th of August, where you can see that further consolidation has occurred. So the idea here is to put this patient on weight-bearing ambulation, because under weight-bearing ambulation, the fibula is going to increase in girth, because as it is going to be loaded, ultimately the fibula is going to become thicker and thicker, and it is going to start looking like a tibia in about a year and a half time.